All right, I will be focusing my talk on metastatic triple-negative breast cancer. I believe Professor Peter Schmid will cover early triple-negative breast cancer later on today. For the audience, this is a typical case you will see in the United States, and I believe you will see here as well. 56-year-old female who was diagnosed in 2023 with a clinical large breast cancer with palpable adenopathy. A biopsy showed it was a triple-negative breast carcinoma. She received neoadjuvant chemotherapy on KEYNOTE-522, carboplatin and paclitaxel, followed by doxorubicin, cyclophosphamide, and pembrolizumab. At surgery, she cleared her lymph nodes. She was node negative. There was a very small T1-MYC tumor left behind. For adjuvant treatment, she completed pembrolizumab, which ended in June. In her follow-up 1 month ago, she presents with jaundice. So if you calculate her treatment-free interval, it depends. If you go by chemotherapy, it's 17 months. If you go by the end of pembrolizumab, it's 8 months. So I'm going to leave that here because it's important that you consider both of those intervals. And on imaging, she has multiple liver metastases. She has bone metastases. She has para-aortic mediastinal adenopathy, and there's a suggestion she also has lung metastasis. So the questions that I will take you through in this presentation is, what is the natural history of triple-negative breast cancer? And the question, should she have gotten more therapy than pembrolizumab? Should we have followed her closely because the technology is available to follow blood tests to see if people are going to be relapsing earlier, perhaps? Is there a role for a biopsy for metastatic disease? And what is the role of next generation sequencing? And then finally, what are her options? So it's important to understand that the definition of triple-negative breast cancer depends on the clinical trial, depends on your society, how you define it and classify it. It's very simple to say it's ER, PR, HER2 negative. Most centers will say it's ER expression of less than 1%. But some centers will include a higher threshold of ER at 10%. They may include ER negative, PR positive disease as a triple negative. So very, very important when you read your studies, understanding how they define their population is critical. It tends to be about 15%, 1/5 of all breast cancers. It tends to present earlier in age, and 1 in 5 is associated with a BRCA mutation. If you look at the global prevalences in the United States, looking by race, it's 2 times more common in Black women. West African ancestry and Ghanaian ancestry have a higher prevalence. The limited data in Bangladesh suggests that 1 in 5 breast cancers in your population is triple negative. It's also important to know that we are evolving our understanding of triple-negative breast cancer, much like we've done with hormone receptor positive disease. There are 4 subtypes that are coming out as being distinguished. There's a BL1 and 2, basal-like phenotypes, mesenchymal and a luminal androgen receptor. If you look at the graph on the right side, you'll see that the mesenchymal type, as well as the basal-like 1 breast cancer types, have a better overall survival compared to the others. Whether this plays out therapeutically has yet to be seen. But triple-negative breast cancer is associated with an earlier relapse. If you compare it to hormone-positive breast cancers, they will relapse within 2 years, whereas most hormone-positive disease relapse within 4 years. So the window of risk of concern that I have in clinic is in the first 3 years. That's when I follow people very closely. And if we know that if they do not relapse in those first 3 years, you can breathe a little bit easier. Never completely easy, but just know triple negative disease comes back early. So the question is, how do we improve outcomes in triple negative breast cancer? What is your approach? If you are giving neoadjuvant chemotherapy, which is becoming a worldwide standard regardless of size, what do you do if there's residual disease? Because we know a lack of complete pathologic response is associated with worse outcomes after neoadjuvant chemotherapy. It is very tempting to say the answer is capecitabine. Recognize that that was done in an Asian population. That was a Japanese study, CREATE-X. And compared to no treatment, observation, capecitabine did improve relapse-free and overall survival. That result has not been replicated in a European population and in an American population. Okay? So the GAICAM trial was in Spain. No change compared to observation in both disease-free and overall survival. They did find there was a cohort of non-basal triple-negative breast cancer, which they defined by IHC as EGFR positive and expressing CK56. It appeared that subgroup of triple-negative breast cancer improved when you gave them capecitabine. In the ECOG American study, it was compared to carboplatin, and again, disease-free survival was similar. So my take is that the established recommendation of capecitabine is very weak. The data is not conclusive. You may suggest it, but particularly in people who cannot afford it, for example, it's not something you can recommend strongly based on the collective data. So what about for people who have a BRCA mutation? We have the Olympia study, and this was done in patients, including triple-negative breast cancer, who had at least a large tumor or it was node positive. It was olaparib versus placebo. And at 3 years, there was an improvement in invasive disease-free survival and an improvement in the occurrence of distant disease. Within that group who had triple-negative breast cancer, disease-free survival was also improved. So there is a benefit to a PARP inhibitor for women with triple-negative breast cancer in the adjuvant setting. What about this question of, should we be following these people more closely? If we know they're going to relapse within 3 years, isn't there a way to follow them better than clinical exam? This is an important study by Nick Turner in Europe. It was called CTRAC. He took women who had newly diagnosed triple-negative breast cancer and stratified them by risk. Either they had moderate risk or high risk based on the disease after neoadjuvant chemotherapy. As you can see, moderate risk, you may have had a large tumor, but it was node negative. High risk, node positive disease. He collected ctDNA every 3 months for up to a year, and he had a group in which they didn't do that. What he shows is you can follow ctDNA, that in all patients, up to a third of women with triple-negative disease will have a positive ctDNA result at 12 months. And at 12 months, if you had high-risk disease, over half had ctDNA positivity in their blood. And it translated as well to what you found on imaging. 70% at the time their ctDNA was positive had metastatic disease on imaging. Almost 30% with high-risk disease had disease at their baseline ctDNA assessment, compared to only 1.4. However, this is the big caveat for all of this. While you can follow it, it has not been made clear this will improve outcomes compared to the way we usually and routinely follow people. So much of what ctDNA is being done today is on clinical trials. So this is not something I'm using, for example, in my clinical practice. So now this woman has recurred. What are the options? This has not changed since the last time I was here. We do rely on next generation sequencing. We do look, and much of this you can do by IHC, by the way. We look for signs that checkpoint inhibitors might be of benefit, whether that's MSI high findings, mismatch repair deficiency, or a high tumor mutational burden. I've never seen it, but it is that rare thing we look for. We look for the NTRK gene fusion protein. We look for somatic BRCA mutations. Even if someone doesn't have a genetic BRCA mutation, their tumor may still carry it. All of these demonstrate an option. This is the lived reality of how common you will see it in triple-negative breast cancer. It is not commonly seen. So next-generation sequencing does make sense if there are targeted agents you can use in your population, and if the other priorities involving the care of someone with breast cancer has been satisfied. And we will hear from my colleagues in Singapore about what we need to look at to help improve the quality of life of women with breast cancer. We've already talked about Keynote 355. You will hear about Keynote 355. You'll hear about Keynote 522. This preceded 522. This was the trial of pembrolizumab in the metastatic setting. These women did not receive pembrolizumab as a neoadjuvant therapy. Okay, so this is a consideration today, but it did show that pembrolizumab had a benefit in overall survival if the CPS was greater than 10, and it was not a better outcome if the PD-L1 score was higher to 20%. So it's not clear today, even though pembrolizumab is 100% an option, if you're now using it in the neoadjuvant setting, are these results still valid? The other drug is sacituzumab govitecan. This is the ASCENT trial. This is an antibody drug conjugate. It uses the trophoblast cell surface antigen 2 as the antigen, TROP2. The payload is SN38, which is an active metabolite of irinotecan, which you cannot give by itself because of toxicity. It was evaluated against the ASCENT trial. It included women with metastatic triple-negative breast cancer. You could enroll if you had brain metastases as long as they were treated and stable. The intervention was sacituzumab, and it was compared to standard single-agent chemotherapy. The results were positive, that this improved both progression-free and overall survival compared to chemotherapy. And if you look at the hazard ratio for death, it was significant. It was 0.43, and the confidence interval did not cross 1. So if you look at the adverse events, what do you need to worry about? It's more hematologic toxicities, gastrointestinal toxicities, fatigue. Those are the major side effects you'll see with sacituzumab. There are others that are looking at targeting TROP2, and these are two, datopotamab deruxtecan, as well as sacituzumab tirumotecan. These are in clinical trials, so you will see more data coming forward about TROP2 antibody drug conjugates. There is trastuzumab deruxtecan, which is TDXD. It was shown, it uses HER2, and it was shown in a phase 1 study in heavily treated patients with HER2 low disease to have pretty promising outcomes. Destiny Breast 04 looked at women with HER2 low disease. You could be ER positive or ER negative. They enrolled a population with hormone positive disease that was considered to be endocrine refractory. And this trial, again, randomly assigned people to TDXD or chemotherapy, and the primary endpoint was progression-free survival. These are the results in the ER negative cohort on Destiny-04. There was a gain of about 6 months in progression-free survival with T-DXd over chemotherapy, and the gain in overall survival was 10 months. It was also far more active to achieve an objective response, and there was no difference between hormone positive and hormone negative disease in terms of its activity. The major side effect, as you may know, that we worry about is pulmonary toxicity, pneumonitis, and it's a significant increase over chemotherapy. If you look at this last column, 45% of people receiving T-DXd had evidence of pneumonitis compared to, 12% had pneumonitis compared to 0.6%. So this is a real phenomenon that we need to be concerned about. You need access to chest imaging to give this drug. Datopotamab deruxtecan, again, TROP2, we talked about this. It was looked at in triple-negative breast cancer in the PAN-Tumor-01 trial. It included a cohort of 44 people with metastatic disease. The response rate with this drug was 34%. Disease control, so not a response, but disease also did not grow in over 3/4 of people. We're also looking at emerging combinations of antibody-drug conjugates with checkpoint inhibitors in metastatic triple-negative breast. There are two that I illustrate here, T-DXd, Dato-DXd with durvalumab are both being done in metastatic triple-negative breast cancer. And the results seem very promising. When you're getting overall response rates of 79 and 60%, this is something that warrants further investigation. This is a sacituzumab and a checkpoint inhibitor as a first-line treatment, again showing a very important overall response rate and a progression-free survival that goes beyond 1 year. These are the ongoing trials that are looking specifically at triple-negative breast cancer, Tropion-Breast05 and ASCENT-04. We look forward to the results that are probably going to either be presented at ASCO or at ESMO. And when we talk about PARP inhibitors, remember, you really want to try to give it early in the adjuvant setting, but if you didn't, or say she did not have a genetic mutation in BRCA, she relapsed, you sent the tumor, and the tumor has a BRCA mutation, there's data from Olympia that addresses that scenario. This was people who had up to 2 prior lines, and compared to chemotherapy, there was an improvement in progression-free survival. Importantly, with follow-up, this does not translate to an overall survival advantage. There is talazoparib as well, which I do not believe is available here in Bangladesh, but the Embraca trial looked at 190 women with triple-negative breast cancer in their study, and there was an improvement in progression-free survival regardless if someone was triple-negative or if they were hormone positive, but again, no improvement in overall survival. And one will argue that with someone living with metastatic disease, that progression-free survival still is important because that's when people are likely to have more to maintain. What about CNS involvement? We know it happens. We know it happens more commonly than with other, with hormone-positive disease. In fact, it may be as high as in HER2-positive disease, but in, the progression patterns, I think this is a really interesting teaching point. The progression patterns are different. HER2-positive disease tends to be stable outside of the brain. Metastatic triple-negative disease, it progresses in both areas. So there are agents that are suggesting we can actually target brain metastases from triple-negative breast cancer. All of these drugs that we've looked at, these ADCs, T-DXd, sacituzumab, datopotamab, there is a suggestion that you can get an intracranial overall response with these drugs. And so that's a very promising. Obviously, doing a larger trial of treatment in a randomized setting is highly problematic. So let's get back to the questions. What is the natural history of triple-negative breast cancer? You can tell your patients the risk they face is a relapse within 2 years of their diagnosis. This is a very aggressive disease, unfortunately, still. Should she have gotten more adjuvant therapy? She did have disease in the breast after neoadjuvant therapy, but she did clear her lymph nodes. The standard of care would have been to suggest the use of something else. She should have been seen by genetics to check if she had a BRCA mutation. You could have offered her capecitabine in addition to the continuation of the pembrolizumab. Should you have followed ctDNA? Because we know that that can be a marker of metastatic disease. It is not yet ready to be utilized as part of routine practice, and it should only be done as part of a clinical trial. Is there a role for biopsy? And what about next-gen sequencing? More commonly than not, will biopsy a lesion at first recurrence. And I will use that biopsy to send for next-gen sequencing. It is a suggested thing to do if you have the ability to utilize the results. And what are our options now? There are multiple new agents we talk about in the clinic in the United States. The sequence of how these treatments should be used is not clear. So if someone is BRCA positive and did not get adjuvant olaparib, I will use that earlier in the course of metastatic disease rather than reserve it as a later line. But if someone is not BRCA positive, then it's unclear which should be used first. I think the entirety of the data suggests one of these antibody drug conjugates is better than chemotherapy in the first few lines. So in conclusion, just recognize that the biology is driving the treatment today. It is true across breast cancer subtypes, but we are also recognizing triple-negative breast cancer is not one disease. 1 in 5 people will harbor a BRCA mutation, so it's very important, because you have access to PARP inhibitors, that these people get genetic testing. The therapy in the US and Europe requires the use of somatic testing because we have access to the drugs that can predict a response to them. Immunotherapy plays a role in the management, but now that we're using pembro in the upfront neoadjuvant setting, it's not clear if you should be looking at an interval of treatment without pembro to decide whether or not to use it again. HER2-low is a target in all breast cancer subtypes and is a target for triple-negative breast cancer. And we need to continue to collaborate for global access because that's the essential way to achieve equity. Thank you very much.